it was always a comfortable place to be. Welcome to this evening's webinar on the acute COVID respiratory symptoms. There's been a lot of requests in Tower Hamlets for some help with answering questions about the acute effects of COVID on the respiratory system, and especially in the current climate with the new variant knocking around. And we're incredibly fortunate to have Will Ricketts, consultant chest physician at the Royal London, and Bart's along with us tonight. And we're very happy to throw this webinar open to our colleagues across East London, in Newham, Dagenham, and all branches of Well and Nell. We have had questions, more questions than any other webinar, I think, that we've run since March, which is amazing. There were over 100 questions. We've collated them into groups. Will has some slides which he'll show as we go along. As ever, if you want to put some questions in the chat, that's also grand. But bear with us as this is a larger meeting than we're normally used to. And I hope that I'll be able to do some sort of Chris Mason type impression for any questions. But I may, of course, have his ultimate skills. I do have, of course, have the best person as backup of Ekremel, and Roberto is along to help us too. So kicking it off, Will, I'm going to throw the first question to you, and this really came from Becky Scott and Victoria Torture Brown in Tower Hamlets. They'd like to know just a little bit on the current situation at the Royal London in terms of COVID patients, numbers of inpatients, perhaps numbers on ITU, or a comparison with back in March, and just generally how they're being managed and mortality rates, and what can we do from primary care to help?
Brilliant, thanks, Phil, and thank you for having me tonight. This is all Roberto's fault. He got chatting to me on Twitter and twisted my arm to do this. And one of the caveats for doing this was that we did it as a Q&A, so that I didn't have to prep anything because we are so busy. But then Phil gave me 90 questions and I realised I probably did need to prep something. Can I just check that you guys can see my screen? Because I'm trying to double screen.
Yeah, that's perfect.
Excellent. But I now, oh, there we go, perfect. I knew that would happen. As soon as I double screened, I could see I lost you, but now we're back. Okay, brilliant. So yeah, just to give a bit of an idea of where we are. So as of today, we have just over 800 COVID patients across the trust. I don't know the breakdown across sites, but to put that in some kind of context, at the end of the first wave, we'd had 2,400-ish across all sites across the whole of the first wave. We now have over 800 in at one snapshot in time in the second wave. So about a third of the total from the first wave at one moment. Again, I think ITU expansion has been similar to last time. We're up at, I believe, around about 80 beds at the Royal London site, and I think 20 or 30 beds at the other sites, but don't quote me on that. And then again, just to give some context, and I think this is certainly for me where things are very different to last time, is in the sort of sick respiratory patients, so those needing high flow oxygen or CPAP, we peaked at probably 25-ish at the Royal London at the peak of the first wave. Now we're definitely over 40, probably approaching 50 at the Royal London. And I think the sort of ratios at Newham and Whips are similar. So there's an awful lot more in that sort of tier, the next tier down below ITU at the moment. So that's kind of the state of the nation, as it were. That's where we are at the moment. To answer the second half, what you guys can do in primary care, so I know actually from talking to Roberto, I think there has been some chat around this. So if Roberto doesn't mind me putting him on the spot, I think I'm probably not the best person to answer that.
Okay. Roberto, do you want to have a few words, and then we'll get on to the next question?
Yeah, thanks, Will, for putting me on the spot. I suppose we've done quite a lot in Tower Hamlets specifically, where I practice, in terms of the home monitoring service. I think that's been really quite helpful in terms of keeping patients who can be monitored at home safely at home. And I know there's been similar home monitorings in other parts of Well and Nell. So I think that's been the priority, really, as well as keeping our access really easy for patients to get in contact with us when they're feeling unwell, in terms of things like e-consults and telephone access, which we've all done throughout the entire pandemic. So I'll hand back to you, Will, because you've got most of the important things to say.
Okay, shall we go on to the first question now, the second question? So this is a question about antibiotics, and Judith Gavin, Rajia Khatun, Simon Malik from Waltham Forest, Alison Smales, Nabila, Melvin, Emma King from Tower Hamlets, and Nadia and Aisha from Redbridge have all asked similar questions. Will, what's the place for antibiotics in COVID, especially if you're suspecting secondary infection, and when should we start, and which antibiotic would you recommend?
So I knew this would happen with me messing around on the screens. Right, there we go. Okie doke. So interestingly, when during the first wave, we were initially told from China, no one has raised CRPs. If they have a raised CRP, it's not COVID. And we rapidly found that to be completely untrue. Certainly all the sick respiratory patients had stonkingly high CRPs. And we then said, okay, in that case, they must all have secondary bacterial infection as well as their COVID. And therefore, our antibiotic guidelines were essentially the same as they were for pneumonia. So you've got severe COVID, you get Coamox and Clary. We then started running out of Coamox, so they had to rationalise that a bit. So it became Amox and Clary for some cohorts and Kef and Clary for others. Then more recently, the data from the azithromycin arm of the recovery trials come out, and that showed absolutely no benefit from azithromycin, which sort of begged the question, is there any benefit from a macrolide at all? Because most of our patients were getting clarithromycin. And similarly, and I don't know exactly how they've done it, but our micro lab have tried to look at the levels of coexistent bacterial infection. Think they're very low. They think they're well into sort of in the single figure percentages, really. So they've recently, as in within the last week, 10 days, changed our trust guideline, which hopefully you can see, but essentially anyone with mild infection, essentially for us that's normal chest x-ray, and I appreciate that's a lot harder for you guys. They don't recommend antibiotics, and even those with an abnormal chest x-ray but not overly tachypneic, not hypoxic, and not with a especially high or low white count immunocompromised, again recommending no antibiotics for that cohort. So this is fairly hot off the press. The other reason I've sort of put the slide up the way I have is, so I don't know if you all know about this, but this app Micro Guide gives you access to the trust predominantly, or is designed to give access to microbiology guidelines, so antibiotic guidelines, but actually it's expanded way above and beyond that. And I think the makers of the app are about to change the name to reflect that. But for us, you can access all the trust antibiotic guidelines, but within the virology section, there's the entire sort of COVID guideline section. So it's not just antibiotics, but everything else as well. So VTE, prophylaxis, and anything else you might be interested in is all in that app. And what I hadn't realised is you can actually download other people's apps as well. So apparently Southampton had better pneumonia guidelines than us a while ago. So I was told to download theirs, which has proved the point to me that you can download other people's guidelines as well. So that's really the state of play with antibiotics. Does that answer the questioner's questions, or is there any follow-up question on that?
Yeah, no, I think that's fine. I think we have been using a lot of doxycycline. I think there were a few questions around doxycycline and maybe not so much amoxicillin, but I think you've answered the question there fully. The next point, I guess there was something about vitamin D as well. Is there a vitamin D answer to Will?
So yeah, so I've just seen that Sabina's put a question on the chat. What I said earlier, please do put questions on the chat, but what I'll probably do is come back to them afterwards, because looking at the number of questions we've had, I think we might struggle to get through all of them. But I will try and answer the chat questions retrospectively. The vitamin D question, so it's an interesting one. I knew that the Royal College of Physicians had put out a statement a while ago, but in prepping for that question, I thought I'd best just double check that that was still held true and wasn't out of date, and found, so this headline, which I'm imagining that might be what prompted the question, but also not only do the Royal College of Physicians say this, but so do NICE, Public Health England, and the Society and Association of Clinical Nutritionists, I think it was, or something like that. But essentially, it's and there is evidence that more people in hospital have vitamin D deficiency, as in hospital with COVID, have vitamin D deficiency than might be expected. There is evidence that those with vitamin D deficiency do worse than those without vitamin D deficiency. But there is as yet no evidence that supplementing vitamin D does anything. And Adrian Martineau, who some of you may know, is effectively the professor of respiratory vitamin D at QMUL, quite a niche role. But he's recently done a comment piece in The Lancet, kind of saying that, as in actually treating with vitamin D once people have COVID, you're probably sort of shutting the stable door after the horse has bolted. They're already hyperinflammatory. That inflammation is going to be shut down more by dexamethasone than by vitamin D anyway. Not yet a proven role for vitamin D prophylaxis, but it seems sensible to be even more sort of strict than normal about making sure that people who would normally be expected to take vitamin D in the winter time do so. So I think the role is checking it and replacing it if it's low, but there's no evidence for any more than that.
Okay, a bit of a supplement from Sabina around, is that because the vitamin D deficient cohort are from BAME backgrounds and thinking of our population in NEL, so is this a factor in a higher risk cohort anyway? Yeah,
good question. We don't know is the answer. I hope we will know. So actually, Adrian is doing a sub-arm of one of the long-term follow-up studies and is sending out sort of blood drop vitamin D level tests. So I guess hopefully we will find out as and when that publishes, but because it's a sort of longitudinal study looking at people who pick up or who end up getting COVID, I don't think we'll know for a long time, but it feels logical, doesn't it? But there's no evidence to sort of back up that logic.
Thanks. And a bit of a supplement on the antibiotic one. Kirsten is asking around whether antibiotics are more indicated for people who develop a new fever around sort of 10 days in after the COVID symptoms and worse seem to be getting better. Is that a cohort that we need to be thinking about secondary infections in?
Yeah, yeah, I guess so. I think it's, if they've got particularly if they've got new fever, I think it's definitely something to think about. As I say, we've seen really little evidence of secondary infection. I think a lot of people do get these sort of relapsing remitting fevers after COVID as a sort of, it's not quite long COVID because it's too soon, but an after COVID phenomenon. And I think it puts us all in a really difficult position. You're not, but I think it's difficult not to treat an otherwise unexplained fever. And I think particularly if they've got focal lung signs, I don't think anyone would say you were wrong for doing that. But equally, I think you can be reassured that you don't feel you need to do it because we really are seeing very little secondary bacterial infection.
So that's Phyllis's point about prolonged fever. You would go, I'm not pushing you either way, but would you tend towards antibiotics for that, or and the role of a chest X-ray?
I think those of you that know me know I'm a chest X-ray man. I do a chest X-ray for everything. So yeah, that is one of our clues as to do we think this is bacterial. As in, COVID generally gives these sort of quite florid bilateral changes, and one of our things that we think makes bacterial infection more likely is a sort of pronounced unilaterality. I'm sure that's not a proper word, but to the X-ray changes. So I think that's a very good indication for a chest X-ray. Absolutely. Okay,
I'm going to move us on because we've got lots of questions in the pile. So but don't forget, as Roberto should tell you, don't forget to mark your chest X-rays as urgent rather than just routine. So the next big topic that I think 10 or 12 people were asking questions about. So Julia, Valerie and Alison from Tower Hamlets, David Darby from Havering, Gilla from Tower Hamlets, Ben, Dan Gilby, Mariam, Selva and Sarah Pocknell from Tower Hamlets, and Helen and Manira from Newham. At what point should we give steroids? Is prednisolone a reasonable option, or should we give dexamethasone? And a few questions around that were a few concerns about asthmatics as well. Am I starting prednisolone at a lower threshold, and is that wise? And is it still okay to initiate prednisolone as we normally would for an acute exacerbation of asthma or possibly COPD too? And the roles, I guess, as well of salbutamol, steroid inhalers, and other points in the management.
Okay, I'll take I'll do the general steroid stuff first, and I'll move on to the asthma stuff. Or remind me if I don't. The steroid one is really interesting, and actually this is, I think, perhaps where Roberto and I started discussing this on Twitter, and I don't know if the other GP that we discussed it with is in the audience, actually, because most people are now just coming up as initials, other than a few of you that have got your cameras on. But I think in medicine we like to do something. We hate feeling helpless. We hate doing nothing. And I think that's one of the massive frustrations with COVID, is there is very little evidence-based anything to do. And therefore, I think a lot of people have jumped on the steroid thing as, is this something we can do? And my natural inclination, I'm a doer, I'm a have a go hero, and my natural inclination would be to absolutely agree with every single one of you that's asked that question, is what harm can it do? And it might do some good, and that's normally good enough for me. But the one thing that puts me off that is, so the big evidence for steroids comes from the recovery trial. So the recovery trial is the biggest COVID trial in the world. I think it's run out of Oxford. There was a recovery trial update yesterday which put some context in this. Leicester have recruited more patients to recovery than the next biggest trial in the world has patients in total, which just gives some context as to how big the recovery trial is. And the initial recovery trial was standard of care versus, and then you got randomized to hydroxychloroquine, ritonavir, lopinavir, dexamethasone, and I think there was one more early on. But anyway, so it's the recovery trial that showed us that hydroxychloroquine doesn't help, showed us that ritonavir, lopinavir doesn't help, and has more recently shown us that azithromycin doesn't help, hence the answer to the antibiotic question. But it's also the study that showed us that dexamethasone does help. But more interestingly than that is dexamethasone helps disproportionately in the sickest patients. And that's the thing that I say puts me off a little bit, this sort of have a go hero mentality, because actually if you look at these Kaplan-Meier curves, you've got, where's my pointing on? There it is. So in the very sick patients, so the ventilated and ECMO patients, you have got this pretty significant, so risk reduction 0.65 or relative risk 0.65 in those that receive Dex. In those receiving any form of oxygen, you've got a still statistically significant relative risk of 0.8. But this is, as I say, what puts me off the kind of have a go hero, should we be using steroids in the community idea, is that actually, although it wasn't statistically significant, the lines are actually flipped in the no oxygen cohort. So if you're not sick enough to need oxygen, there's definitely no evidence that Dex will do you some good. And whilst it's not statistically significant, that to me is enough to get me twitched that there's potentially even a risk of harm, but definitely not doing any good. The other steroids, there is some evidence for hydrocortisone, but nowhere near as strong as dexamethasone, more because the studies weren't powered, but equally this is now this is the study that's shown it, and therefore that's the regime we're going for, is Dex 6 milligrams once a day for 10 days. I don't know where the recovery team got that dosing regime from, but it does leave it as the main evidence-based regime, and it's putting us in a spot of bother. If people are still sick at 10 days, do we carry it on because they're sick, or do we stop it because that's what the evidence says? So that's Dex. I think the one thing, because they put oxygen versus no oxygen, this is the WHO guidance, because I thought it was just useful to have a sort of a consideration of what oxygen might be. So they've set a threshold of less than 90% on room air, which to me is a cohort who should more than 9 times out of 10 be in hospital anyway, although they admit that that is their own sort of grade D evidence threshold, and that actually thresholds of anywhere between 90 and 93 aren't unreasonable thresholds. But that's the sort of ballpark we're talking about as to people who might benefit from dexamethasone. I'm not aware of any evidence for prednisolone at all, but if Dex works and hydrocortisone works, why wouldn't Pred work? I think there's sort of lab evidence that inhaled cyclesinide might help, which was one of the things we were talking about. And I believe there's a trial of inhaled corticosteroids in community COVID. I don't know if any of your practices are signed up. I don't know how you get signed up, but that's I think that is one option of, if you think steroids help, you want to help, then that's definitely an option. Ricardo, did I see you taking a photo? I'm planning to share the slides with Phil so that he can share them all with you. I just need to slightly edit out some of the more controversial ones and the ones that don't belong to me. But I will share the slides after I've done the editing. So that is steroids in general.
Just a brief point, Will. Archner is asking about are the people in the recovery trial in the community, and if so, should we not be using dexamethasone in the community? Is that what you're saying, really?
Yeah. So as I say, the evidence is unless you need oxygen, you shouldn't. There's no evidence for steroids. So, and if my personal opinion, although I think we might discuss it in more detail later, is if you need oxygen, you should probably be in hospital. So I wouldn't advocate using steroids, or I certainly wouldn't advocate using oral steroids in the community. Thanks, Salvo. You put it's the principal trial from Oxford. That's brilliant. That's the one. I don't know how you sign up, but it strikes me as a very good trial to be part of, because I think it's a great question.
Okay,
yes.
We're going on to those bits around prednisolone for asthmatics. Is that the next bit to pick up?
Yeah, unless anyone had any more on where we were, then yeah, that's what I was going to go. There we go. So the asthma and COPD are so when I send this round, this will actually be a hyperlink and you can access it. But essentially, the British Thoracic Society have done a whole sort of raft of quick guidance and quick access guidance on all sorts of respiratory related COVID things. And the asthma one and the COPD one are both about 3 pages. So not exactly huge, but the principle for both of them is that just pretty much manage it as you would. So I don't know if you remember, but early on there was a paranoia that steroids might actually do harm, and there was a bit of a paranoia about should we be avoiding giving steroids to particularly our asthmatics. That's clearly been massively overridden and swung in the opposite direction. But even at that time, the mantra was no, treat asthma as you would, and the mantra still is. So there's no suggestion of sort of getting in early, but equally there's no suggestion of avoiding steroids either. Interestingly, we're not seeing huge numbers of asthmatics or COPD patients in the hospitals, and we don't quite know why that is. I don't know if they're shielding well and therefore not getting COVID, whether because they're trying to shield, they're not only not getting COVID, but they're also not getting all the other winter viruses. Whether they're, certainly in the first wave, when there was so much less traffic, there was a feeling that there was less pollution and therefore there were less non-infectious exacerbations as well. And then there's also a feeling that COVID is an alveolar disease, not an airway-centric disease, and therefore these people aren't any more prone than anybody else. So that's sort of the general consensus around asthma COPD, is essentially treat it as you would. I'll just quickly looking at the chat.
There's a couple of things then that relate to other questions. I'm just going to fire them at you if you could give the answer. So, is there any suggestion that salbutamol or a short-term or a steroid inhaler or a long-acting beta agonist is any help at all, either in asthmatics or in people without asthma?
So, as in help for COVID, as the question's gone off the top of my screen, help for COVID or help for asthma?
So I think help for COVID. So
there's some lab evidence for what would otherwise be inhaled cyclesinide. There's no no real world evidence for it. I think probably the one thing to say with asthma and COPD is, if you can, and I appreciate you guys are crazy busy as well, but this is a time for making sure that your patients are on their inhalers appropriately and taking them appropriately, because you definitely don't want COVID and asthma or COVID and COPD together. But I don't think you specifically need to change anything because of COVID, but it is about kind of getting the basics right, really making sure your asthma patients are taking their inhalers and are on the right inhalers.
That's grand, thanks. And no real evidence for using salbutamol in patients who aren't known to be asthmatic?
No, not in non-asthmatics, no.
Okay. Just before we go on to admission criteria, because I know that...
Actually, Phil, before you move on from that one, I don't know, I think it might be a question we weren't necessarily going to cover. There was one question about chronic cough.
Yeah.
And that might, the two...
I think, Will, you've muted yourself.
Sabah Khan from Barking was asking about management of chronic dry cough. Also put in a little bit of a question about an article in Science about interferon autoantibodies, which I thought was a very interesting sort of apposition of something that is very common and something that is very scientific. But I guess if you could answer the chronic cough one, that would be really useful.
Yeah, I'll stick with the chronic cough one. There was definite curveball with the Science article one. I'll let the immunologists answer that another day. But the chronic cough one, I think leads on from some of the inhaler one. Actually, there's no evidence that I'm aware of for any treatment for COVID chronic cough, and COVID chronic cough is quite common. But the people are recommending low dose opiates, so codeine, as a treatment for chronic cough, and I assume that it might work because sensible people are recommending it. I've not seen anyone recommend inhalers. If you were going to try an inhaler, I would go for an inhaled corticosteroid and not a short or long-acting beta agonist, because that's what works far better in normal chronic cough than short and long-acting beta agonists. So if you wanted to throw something at your patient, I would go for low-dose opiates first line and inhaled corticosteroids second line.
Grand, thanks. And just to finish off the therapeutics before we get on to admission criteria, which I know you're all champing at the bit for, Becky Scott was asking about the role of DOACs in management of inpatients, and should we be considering this use in the community, and if patients are discharged on DOACs and remain unwell once the course is finished, should we continue prescribing that? Is that something you have an answer for? Is that more a haematology type?
No, I'm disproportionately happy to answer that, because I've ended up sitting on so many meetings with the haematologists. I feel like an honorary haematologist now. Peter McCallum, Louise Bowles, Tadbir Bariana, and I spent a lot of time early on in the first wave thrashing some of this out, and we ended up on various panels about this. So this is our best guess, but currently NICE do not back us on this. So NICE understandably need evidence, and there is no evidence. But there was a strong feeling early on that we were seeing lots of patients with high D dimers. We were seeing, and I think some post-mortem series from Guy's and St Thomas's were seeing a lot of thrombus in situ. Some very fancy scanning that they were doing at the Royal Brompton was showing lots of microemboli. So there was a strong feeling that thrombosis was playing a part in what was going on, and therefore we that sort of grade D evidence again, but quite widely held expert opinion that we should be doing or trying to do something about this, and therefore we came up with this rather complicated algorithm for VTE prophylaxis, which essentially boils down to, if you're overweight or your D dimer is more than 3, you get double the dose of VTE prophylaxis that you would normally get. There was then quite a concern that patients that we were discharging were representing to A&E with chest pain, hypoxia, breathlessness, or a permutation of the 3, and that some of these had post-COVID PE. And that prompted our haematologists to suggest that on discharge, patients should have 2 weeks of prophylactic dose apixaban on discharge. The feeling being that they were still probably procoagulant from the virus, they were still probably relatively immobile compared to their normal baseline state. And that's where the 2 weeks of apixa came from. So to answer the question, there's no evidence for it. We think it's the right thing to do. NICE don't. We are probably pretty bad, I think, at actually prescribing that 2 weeks. I think this is one bit of the guideline that our juniors overlook. I think they're absolutely red hot on this top bit, and I think they completely ignore this bit. And actually, the haematologists are planning to audit how many patients are discharged on 2 weeks of prophylactic apixa. And then to answer the second bit of the question, what should you do after the 2 weeks? So our plan wasn't to extend it beyond the 2 weeks. And we realised that we're going slightly off piste, even recommending 2 weeks. But equally, I think if your patient is still immobile and potentially still procoagulant at 2 weeks, I think you could consider it on a case-by-case basis. But the reason we went for 2 weeks was a bit of a hodgepodge of the orthopaedic evidence and what felt like a sensible thing to do. So you are as sensible as any of us, and I think at the end of that 2 weeks you can make a call, but I wouldn't expect that many patients to still need it at the end of 2 weeks.
Thanks. Before we aspirin.
So aspirin has been adopted as one of the newer arms of recovery. They've gone for a dose of 150 milligrams once a day, and unlike Dex, which they stopped at 10 days, aspirin goes on forever, or well, not until discharge essentially. But it won't, I guess it won't answer the question from your points of view of what's the evidence for aspirin after discharge, but at least it will answer the question of what's the role for aspirin during admission. Frustratingly, So actually just going slightly, well, that's reminded me to go back to low molecular weight heparin in particular, but we pushed really hard to get low molecular weight heparin as an arm of the recovery trial, and they didn't let it in. And then for some reason, months later, they went for aspirin. We pushed hard to get our own trial of low molecular weight heparin and were basically turned down because we were told, no, you've got to enroll all your patients into recovery. And then there's another trial. So the other main active trial at Barts Health is one called REMAP-CAP, and that has recently reported that there is no evidence for intermediate dose thromboprophylaxis. However, we, not just I, but think that should be taken with a massive pinch of salt, in that REMAP-CAP, the entry criteria, you have to be sick enough to be in intensive care, essentially. And I think for those patients, they're already that sick. The aim of this is to try and prevent people getting sicker. So it doesn't surprise me that there's no evidence for enhanced prophylaxis in the group that are already at their sickest. I think you're, again, sort of shutting the stable door after the horse has bolted. So it doesn't surprise me that REMAP-CAP is a negative trial for low molecular weight heparin, but I don't think that's the cohort where I would have ever expected it to work anyway. There was another question about suspecting PE.
Can we deal with that one later, because we have another specific question about PEs later.
Okay.
That's possible. Unless you want to go on to the PE.
I just thought they naturally followed each other.
Yeah. Shall I give you the question from? Let me just find it. So, from which day do COVID patients?
You know that story. Just submit it.
Could you mute yourself, whoever it is that's talking, please? Thanks. How can we differentiate from PEs from chest infections in COVID patients from the history? How common are PEs compared to chest infections in COVID? And from which day would you might expect a COVID patient to develop chest symptoms?
So the PE question is a bit of a hot potato, and has become even more of a hot potato this week, much to my frustration. I'm not quite sure what happened over Christmas, but apparently A&E arranged 36 CTPAs in roughly the same number of hours, and 35 out of the 36 were negative, and this has caused the radiologists to understandably get very upset. So we are definitely seeing PE. I don't know if it's the enhanced prophylaxis. I don't know if something slightly different seems to be going on this time, because actually it felt like, in fact, if I go back to my previous slide, it felt like in the first wave, loads of patients had D dimers greater than 3, loads of patients were getting enhanced prophylaxis. Now this might just be pure recall bias on my behalf, but this time it feels like they're all in this group. Everyone has a D dimer somewhere between about 0.6 and 1.2. So I don't know if this is, as I say, recall bias on my behalf, confirmation bias on my behalf, something to do with changing strains, something to do with the cohorts of patients that are now getting it. But it feels like we're seeing less PE in the second wave than we did in the first wave. It feels like we're seeing less high D dimers in the second wave than we did in the first wave. And so we're not seeing loads and loads of PE, and we're definitely not seeing, as I say, from this little snapshot in A&E recently at least, we're not seeing loads of PE up front. I think they may be developing PE in hospital. So I think for you worrying about patients at home with potential PE, I think the risk is relatively low. To answer the question about differentiating symptoms, I don't think there is any way to differentiate symptoms. And as some of you know, my day job is lung cancer, and that's a big bother. It's actually quite difficult to differentiate, is your cough because you've got a normal chest infection, COVID, or lung cancer? Is your chest pain because you've got a PE, a pneumonia, or COVID? And so on and so on. I don't have any particularly helpful answers, to be honest, other than your expert clinical acumen, which I know you all have. And then the last bit, interesting about post-discharge PEs. So we definitely had this worry in the first wave, and that's where the extended prophylaxis idea came from. and we definitely had some. I don't know how many we're getting now because they don't come via me. They go via A&E and ambulatory care. So I don't know if we're still seeing that, or if that has improved. The flip, or the sort of the next step, if you like. So in the after COVID clinic, again, we are seeing almost no PE, but I believe at other centres they have seen a fair amount of PE. So I don't quite know how to interpret that, but we have seen next to no PEs in the after COVID clinic.
Thanks. Okay, there's a few more questions, but I think we'll pick those up. Otherwise, we'll never get on to the next question, which loads of people have asked about. At what stage should we refer patients to hospital? So especially patients with positive results, and especially those who are perhaps more reluctant to go. And what can we do to keep them in the community? Is there anything to improve prognosis? Are there agreed characteristics or measurements that would indicate supportive care in the home would not lead to a worsening of prognostic outcome? And the point I think that Elliot raised, are the goalposts moving, and are they likely to move imminently in terms of the capacity of our colleagues like yourself at the hospital to manage in terms of numbers?
So I sort of had to phone a friend on this one. So for me, all the patients I see are sick, and I don't actually see the people at the front door anymore to know who needs to come in and who doesn't. So I'm sort of not the best person to answer this, but so a bunch of us actually gave a bunch of talks for Medical Aid for Palestinians a little while ago, and Emma Young, one of the ED consultants at Newham, gave the kind of front door talk. So I nabbed all her slides, but particularly this slide is the one that sort of alludes to that question. So I double checked with Tony Joy today to see if he had anything more up to date, because he obviously runs the physician response unit, and he pinged me the same slide that Emma had used. So this was apparently designed in July, but is still the current guidance, and you're sort of extrapolating from it, but this is what A&E would use. So A&E are saying if your SATs are greater than 95 on air, greater than 93 on exertion, you can pretty much go home. So I think for your cohort, if they meet that criteria, then there's no real advantage to referring them to A&E, because that's what A&E would do. And I don't know, I think it's just started, hasn't it? But the home monitoring scheme, although I've seen the kind of principles of who to refer and how to refer, what I haven't seen is the cut-off points that lead to sort of an action taking place. But I assume that the cut-off points are similar, if not the same. So to me, I think if their SATs are, in this range, then definitely don't send them to A&E. I guess if you're worried about them, and I think it's quite reasonable to be worried about them, that would be a cohort to refer to the home monitoring scheme. One of
the issues is that the home monitoring service is probably slightly different in trusts across the patch. So you may need to discuss that with your home monitoring services wherever you are. Certainly in Tower Hamlets we could comment on that, but I'm not sure what happens in other boroughs. I know it's slightly different. Sorry to interrupt, but that's
that's really, I've only seen, I think I've seen Tower Hamlets and possibly Waltham Forest, but I definitely haven't seen it anywhere else. This next cohort is obviously the borderline cohort, and so SATs in the sort of greater than 93, greater than 90 range, and I think so. I'm sort of going to come back to them. This lot, so SATs less than 93, less than 90, I think you obviously really need to be getting them into hospital, because they are the ones that we would definitely admit. I think this cohort, and I think then obviously some of the more nuanced questions about patients who don't want to come and all those kind of things, I think these are the ones where you have to have a discussion with the patient, and it depends on the patient's capacity. It depends on why the patient doesn't want to come. It depends on their homes, all the normal stuff that you're far more expert on than me. Their home setup, how sensible they are they really going to come if they get worse? I think the thing to reassure you is that other than dexamethasone, we don't have any disease modifying drugs, as in everything we do is supporting the patient's physiology. It's not changing the underlying disease process. So by not giving them oxygen early, you're not changing their outcome. But obviously the need for oxygen, generally speaking, is a need to be in hospital. I know there's lots of opinions about actually having oxygen at home or having oxygen in nursing homes. I think those are they're very complex discussions, and I think they have to be, you have to consider it in a patient who has capacity to make that decision, capacity to understand the decision they're making. Because on the one hand, you're pretty much saying, I'm limiting you to a maximum of 6 litres. What happens if you need more than 6 litres? And therefore, what are we hoping to achieve by giving you up to 6 litres? And as I say, there's some strongly held opinions on that, and I don't think there is a right answer on that. But I think it's knowing the conversation you're having is really sort of where I would go with that. Sorry, it's not. I've waffled a bit. It's not the most helpful answer, and I've missed a few bits, I think, from the questions, Bill.
Thanks, Will. The issues I think were around. I think Elliot was asking really whether the goalposts were going to change. I don't know if you've heard about that. There's been some rumours that that's going to drop from the admit rate is going to drop from 93 at rest down to 91 or 90, but that may be just a reflection of the number of patients that are very sick and coming in. But that would, I think we all have a slight anxiety about managing patients with that level of oxygen saturation in the community, as this slide sort of suggests, really. So I hadn't heard that. I can understand why people are talking about it, and I agree, it would make me anxious as well. My mantra has always been, if you need oxygen, you need to be in hospital. But I appreciate there is pressure on beds, but that's my personal feeling, and I've not heard anything different. Sure. Alison is asking the question again about DEX, so I'm not sure if you were around earlier for that, Alison, but the question would be about the moderate group who decline admission. Should we be starting dexamethasone in the community? I think you've sort of implied that. Not so the case. Would they slip into the second graph along then?
So yeah, I think because I spotted Alison's question in the sort of mass questions earlier actually, and that's why I put the WHO thing in as to because obviously recovery just said oxygen yes or no, but didn't talk about thresholds for oxygen and so on. So it's pretty borderline, isn't it? But if you follow WHO, if they've got SATs less than 90, then they would definitely recommend DEX. If they've got SATs in the 90 to 93 range, they might recommend DEX, and that is pretty much the ranges we're talking about for admission. So I get Alison's point, actually. I think if you've got a patient who has capacity, is refusing to come to hospital for whatever reason, and has SATs less than 90, definitely go for DEX. SATs less than 93, why not? But ideally, they'd be doing it in hospital. But I completely get it. If there's reasons, whatever they may be, why they won't come to hospital, then I think it's one of the opportunities you have got to give some kind of evidence-based intervention at home.
And I think Nabila is making the point from her experience that I think Guy's and King's are doing that in a package for patients who are declining admission, and being clear that it's not admission avoidance, it's the issue around the fact that they're declining admission.
Yeah, and I think that's really important. I agree with that, Phil. I think it is the capacity to decline, and declining with that capacity is the potential cohort.
Just a quick question about the dose of DEX in the community.
So the only evidence-based dose is 6 milligrams once a day. So if you want to follow the evidence, that's what you got to go for. 6 milligrams once a day for 10 days. We're giving nearly everybody accompanying PPI because of the sort of GI bleed risk.
Okay, I'll put that in the chat so that when we print it off, then that's there as an answer. Okay, so thanks very much to Darragh from Waltham Forest, Hina Khan, Anissa, Claire, Nirupam, Jenny Reed, Ibaronki, Kirsten, and everyone else who asked that question. If we can move on a little bit now to some more questions. Lily's asked this 3 times, so I must ask that before we go on. Is there any benefit from prophylactic aspirin?
So we don't know. When recovery reports on the aspirin arm, I'll let you know, but it's a fairly new arm, so I'm not sure how soon they're going to report on it. Okay,
thanks. And I'm going to ask you a brief question because you got a little bit dissed by Anna earlier for suggesting codeine linked us.
I saw that out the corner of my eye, and I decided to strategically ignore it.
So Anna put in a question early on and before tonight. I think it's useful for all of us who deal with patients with substance misuse issues. So do you have any specific experience in relation to problem substance users, particularly heroin, crack and alcohol, in relation to COVID, given the respiratory effects of the first 2 and asthma triggering and instability?
I'm going to slightly answer Anna's. I only, as I say, I only saw it out of the corner of my eye, Anna. But your question about codeine links is a good point, and it's really interesting. So just going to chronic cough in general, so parking COVID for a moment, the British Thoracic Society guidelines do not recommend opiates. However, the much newer European guidelines do recommend opiates. One of the reasons they recommend them, or the way they recommend them, is to do a short, sharp trial, and then if it's going to work, it works quickly. But I must admit, it's not one. I'm still a bit stuck with the British guidelines, and I tend to not recommend them. So that's the opiates in cough in general, which I guess we might extrapolate to COVID.
Okay, I think Anna's major point was more about substance users with crack.
Yeah, I was going to come to that, Anna. I just so the drug and alcohol one. In fact, Anna, did you want to ask your question, because I don't want to lose the nuance of the question.
Okay, well. As people in Tower Hamlets know, I'm clinical lead for Precept. That's the primary care drug and alcohol service, and work closely with the Reset, the commission service. And certainly in my clinical experience in the past, not in relation to COVID, there have been a lot of acute admissions with things like acute asthma and so on, because quite apart from the long-term COPD from a mixture of smoking and these various substances. So my hunch would be that people were much more susceptible to getting complications of COVID, but I don't know that that's really been experienced. So I was wondering what your experience is.
Yeah, well, it sounds like your experience is absolutely the same as mine, as in general, our particularly sort of crack and heroin smokers get severe early onset COPD. Also, a lot of the cannabis smokers seem to get severe early onset COPD. And there seems to be this intertwining of particularly with heroin, intertwining of worsening breathlessness, smoke more heroin to manage the breathlessness, and then reach a tipping point where they end up in hospital. And then there does seem to be some bronchospastic effect sometimes as well. So they seem to have a sort of asthma COPD overlap. Not a bit like the asthmas and COPDs in general, really not overrepresented in our COVID population. And again, a bit like the asthma and COPD patients in general, I don't really know why that is, because it's a surprise. I would expect them to be, and they haven't been. And unlike the more general asthma and COPDs, you would think that perhaps they are less good at shielding and looking after themselves. So it's perhaps even more of surprised that they aren't overrepresented, but they really don't seem to be. But I don't know why. So I think my experience is the same as yours, Anna, but I don't know why that is.
I just wanted to throw in two things really. One of which is that nationally there has been an increase in deaths, drug-related deaths, although locally so far it's not really up, although it's not quite clear because we're not at the end of the year. And secondly, we have got permission in Tower Hamlets to allow major drug and alcohol problems to be vulnerabilities for flu injection. And I wondered whether you had a feeling about COVID injection, because my feeling is that it would be definitely worth getting those included because of protecting others as well as themselves in the community.
Yeah, so my gut feeling is we have seen more overdoses in recent times, but how many of those are in pre-existing drug and alcohol users, I'm not sure. And I agree with you that those cohorts ought to be near the top of the vaccine list, although I think obviously everyone wants to be near the top of the vaccine list at the moment, but I agree they ought to be one of the cohorts pushed forward to be at the top of the vaccine list.
Thanks.
Thanks, and I'm going to go back to the questions that were submitted before. Dr. Femi, I can see your hand is up, but if you pop your question in the chat list, then we'll try and come to you if we can. The next question is from Rachel Bauer. She's asking, is there anything to improve prognosis at home without oxygen? Anything else that you might think we could do?
No, afraid not.
Okay. The next question is from Munesh Mistry from Waltham Forest. Why do some patients with COVID have breathlessness but normal chest X-ray? More patients now positive with COVID have strong ERTI symptoms in addition to anosmia. Is this the new variant contributing?
So breathlessness with normal chest X-ray, I assume you mean in acute COVID, breathlessness with normal chest X-ray is one of the things that makes me a bit twitched and is one of the things that makes me think about doing a CTPA. That said, in reality, most of them, it's the chest X-ray changes lagging behind. So those that we do sort of follow up semi-longitudinally, so the inpatients, what often happens is on day one of being in hospital, they have a relatively normal chest X-ray. We get twitched. We do a CTPA. There's no PE, but there are subtle COVID changes on the CT. 3 days later, we do a chest X-ray and they've got florid COVID changes. So I think most of them, it's the chest X-ray changes lagging behind the clinical picture, but it's certainly a cohort that makes me twitched about PE, and that's one of the cohorts I do frequently CTPA to look for PE. The reverse, so after COVID, the breathlessness after COVID with normal chest X-ray is interesting. We see a lot of deconditioning, and that was the main thing I expected to see. So that's the main cause of our post-PE breathlessness is deconditioning. But we're also seeing a lot of breathing pattern disorders and to a lesser extent vocal cord dysfunction as well. And then there seems to be all the sort of more musculoskeletal type causes of fatigue, and then trying to disentangle what's fatigue and what's breathless and so on and so on. So there's plenty of reasons in after COVID to be breathless with a normal chest X-ray as well. And sorry, Phil, I've forgotten the second question or second half of the question.
Okay, the second half of the question was, is the new variant contributing to this slight difference in signs from more ERTI symptoms?
Honestly, don't know. I think it's probably a sort of a recall bias, confirmation bias type thing, probably from us and the patients. Is once anosmia got hyped in the press, people suddenly knew about anosmia. But I think the upper respiratory tract infection or sort of upper respiratory tract symptoms were always there, and that's why so many ENT clinicians came down with COVID early on. They were massively overrepresented amongst medics because patients were presenting to them with those symptoms. And I think that's probably why. So no, I think it's probably a recall bias, confirmation bias type thing rather than a genuine change in sort of pathophysiology.
Okay, thanks. I'm just picking up a few things from the chat list. Please just answer yes or no, unless you want to expand. Is there any role for high dose pred as opposed to dexamethasone to avoid side effects?
No evidence for it.
There's a couple of people asked about ivermectin and lactoferrin in early COVID. Is there any evidence it's being used in places like Egypt?
Yeah, not yet. So ivermectin is highly likely to be adopted as a new arm in recovery fairly soon, but there's not currently any evidence for it.
Okay, and any evidence for fibrinolytic agents as prophylaxis in severe COVID post-ITU in patients with no background of lung pathology?
I'm not sure what you mean by prophylactic fibrinolysis. To me, fibrinolysis is for massive PEs and MIs before we have primary PCI. So I'm not quite sure I understand the question.
Okay. Well, we'll leave that. If you want to expand on that question, Marion, please do in the chat. And Subir Sen, if you want to put a question in the chat, please do. There was a question about 6-week post chest infection chest X-rays. Are we still doing those?
Yes, please. Although maybe not as early as 6 weeks. So the rationale for 6 weeks comes from standard pneumonia, and the reason for it is to exclude an underlying lung cancer. Because most of these patients have bilateral changes rather than unilateral changes, and because a decent chunk of them are younger and they're less likely to be smokers proportionally, just because COVID is so common, not because it doesn't affect smokers, the sort of guidance has been relaxed a bit. So yes, we do like a post chest X-ray, but it doesn't need to be quite as soon as 6 weeks. We're sort of saying 6 to 12 weeks rather than the sort of traditional 6 weeks.
Wonderful. The time has reached 7:30. With your permission, Will, are you willing to carry on for just a little bit longer?
Yeah, absolutely. My wife's not home yet, although she has texted me. So let me just check. Oh, she's running late. Yeah, I'm good to go.
Okay. So with everyone else's permission, if you'd like to hang on, I know we normally stop at 7:30, but I think the questions are so rich, and there are still some questions that we haven't answered yet. Felice is saying something I'm sure that all of us are slightly worried about. When can we stop worrying about patients? What's the timeline between developing first symptoms to admission? She's seeing quite a few patients being admitted around day 10 to 12 just after they seem to be getting better.
I've got a couple of slides on that, partly because I thought they'd illustrate it, but so this is an early slide. This again is one I've stolen off Amir Hakim, who's one of the academic respiratory physiologists at the university, although he's clearly stolen it off other people as well. And this was sort of the early mantra, was there was this sort of 7-day window of being potentially an asymptomatic carrier, and then this kind of progression, and that once you were past a certain point, then you were safe. Now we are, or it feels like anyway, we are seeing a lot more patients like you describe, or like the questioner described, of presenting later. And I think that is really true, but it might be a little bit of some kind of cognitive bias in that for us, the cutoff for using remdesivir is less than 10 days after starting symptoms. So all of a sudden we've been acutely aware of that magic 10-day number. And it feels like we are using remdesivir on less than half of our patients, therefore suggesting more than half of them are beyond the 10 days. And it didn't feel like that in the first wave, but then we weren't looking at that sort of quite the same level of detail because remdesivir wasn't on the table at that time. But yeah, I agree, it does feel like people are presenting later. And I think my next slide, so I've stolen this off Bridge Patel. So this is the one. Please don't take a photo of this one. This is the one I'm going to edit out before I share these slides, because it's not my slide to give. And as Bridge points out, this is already under peer review. But I thought it was a really, so Bridge is a intensivist at Imperial, and he's done a lot of work on this kind of trajectory thing. And I just thought this slide absolutely, it's not quite why he's done it, but it shows what's happening. You've got these patients kind of yo-yoing around, or as I've sort of called it, roller coastering around. So, you know, if most of us see a patient with a standard bacterial pneumonia, you've got a pretty good idea what their trajectory is going to be. COVID, it's a lot harder to predict. You've got patients who start sick and get better. You've got patients that start well and get worse. But a lot of them seem to bob around and have good days and bad days, or even good half days and bad half days. And so that sort of trajectory of how they're going to behave, I think is incredibly difficult. And yeah, I mean, it doesn't sort of answer the question as such, but yeah, I'm not surprised you're seeing patients deteriorating at day 10, 11 and 12, because so are we. And equally, I'm not surprised that you see patients, you know, that appear to be getting better then get worse, because again, so are we. So I think the take-home message from my point of view is to reassure you that everybody is seeing that. It's not just you. But it doesn't, and I think that's all I can say on it really, is just to reassure you that that is happening. It is real.
So we can't ever feel entirely comfortable, I think, and that probably is for the whole of the last 9 months, isn't it? There's a specific question from Subia around, are there actually any protocols as the FDA has approved in the States? Do you know of any primary care protocols for COVID?
I don't. I'm probably the least qualified person on this meeting to answer this. I think there's 120 people more qualified than me to answer it, but no, I don't is the answer.
If anyone has the answer, pop it in the chat for Subia. There's a couple of questions have been about long COVID. We've specifically not dealt with long COVID in this webinar because I think that's the topic for another webinar in times to come. So if you'll excuse us for that. Salma's asked a specific question around chilblains and COVID toe or COVID finger. It's not a respiratory question, but are you seeing people with just painful digits with no temperature or cough?
Yeah, me. So my first COVID symptom was Raynaud's. I got Raynaud's before I got anything else. I probably haven't seen any others because they're not the end of the spectrum patients that present to me. But yeah, from personal experience, I got Raynaud's 2 days before I got upper respiratory tract symptoms.
That's fascinating. Perhaps you'd have a chat with Mrs. BR about how when you next see her.
Yeah.
Okay, and Julia's asked this question twice, so I must ask you, how many days of COVID can people with no or low infection risk attend for a chest x-ray? So when do we, I think the question really is, the last thing we really want is to make sure that we're spreading COVID around. What's the guidance on time to go for your chest x-ray? Is that right?
As in, at what point do we start worrying? This is, I guess the question is why you're doing the chest X-ray, and I guess if you think they've got COVID, but you don't think they're sick enough to be in hospital, then I wouldn't do a chest X-ray for the risk of spreading COVID. If you're worried that they have something else, then you generally are probably going to try and wait until either you're sure it's not COVID or their COVID is non-infectious before you worry about the something else. I think so. As in your potential underlying lung cancer or whatever. I think the one cohort where it's really difficult is this a bacterial pneumonia cohort, and I don't really know the right answer. My gut feeling would be to have a slightly lower threshold for giving antibiotics off spec without a chest X-ray to reduce that risk of contaminating the radiology department. But that's more of a gut feeling, I think.
Okay, I think Julia's after. Julia, do you want to ask the question yourself? Are you asked after a number of days after when it might be safe for a carer to visit or go for an X-ray or whatever?
Yeah, thank you. It was more about the risk of infecting other people. So my patient was discharged. She was not very well, needed someone to come and look after her at home, but was worried about passing on COVID to a family member. So my sense is that's about time, not about any investigations, but it would be helpful to know what you think.
Agreed. So we have been trying to just follow the standard government guidelines. So at 10 days you shouldn't be infective unless you've been sick enough to be on ITU, in which case it's 21 days. But yeah, that was actually the other reason for putting this slide on, was this sort of contagion period. Although again, it's not exactly, it's a bit out of date, and you've got to remember that this day zero is when you catch it rather than when you develop symptoms. So you've got to knock sort of 8 off these numbers, but essentially it roughly fits with what the government are saying of 10-ish days, and then you shouldn't be contagious anymore. There's no evidence for swab PCR conversion as to whether you're still infectious or not, because swabs pick up dead virus as well as they pick up living virus. So there isn't, the only test to say you are no longer contagious is viral culture, and we don't routinely do viral culture. So yeah, there's nothing in swabbing or chest x-rays to say you're no longer contagious. So yeah, we're just doing it on time as per government guidance.
Okay, that's really useful. I think that's answered Alina's question as well. So the guidance is 10 days and was 14, but you can't test for it. I'm going to just go to a couple of other questions that we received, and again, they're probably going to be just short answers. Are you seeing, this is from Jasmeet Satchar from Barking and Dagenham, are you seeing costochondritis and myositis tendinitis of chest muscles with COVID-19?
Yes, is the short answer. Yeah, absolutely.
Okay. From Imran Kazi in Waltham Forest, a specific question about methotrexate. Managing immunosuppressed patients, for example, on methotrexate, who develop COVID in the community, is referral criteria different, and should they skip their dose of methotrexate for the weekly basis?
So where's it gone? So in our antibiotic guideline, we've suggested that people that are immunocompromised have a lower threshold for being given antibiotics. I doubt I don't think there's any evidence for most of this small print stuff, but I think it's probably sensible to skip a dose of methotrexate or any other immune suppression, but it's obviously balancing risks of whatever the reason they're taking it for. But yeah, we're tending to withhold them in hospital. So yeah, if it's something you'd normally withhold it for, then I think you should, yeah.
Okay, there's another question from Aaron Patel in Havering on a similar line. Are you stratifying lung conditions into risk groups for complications from COVID to help advise patients about shielding? For example, does interstitial lung disease pose a greater risk?
So we have generally just followed the general advice on shielding, which I think is severe asthma, COPD, severe bronchiectasis, and I think ILD, but we haven't sort of stratified them within that. And actually, I think most of the shielding process was primary care led, although I know we did a second pass, particularly for the bronchiectasis and ILD patients.
Great, thanks. So he's put a cheeky question in as well around, are you advising your most severe long-term lung conditions to continue shielding regardless of the government easing?
Yeah, the cheeky answer would be yes. I think it is sensible to, I mean, obviously that's slightly, since Boris's announcement, that's 2 days ago, that's now reverted anyway. But yeah, I think my advice is if you can, you should. But obviously, yeah, if you start losing government support, then it becomes a lot harder to. So yeah, it's tricky. But yeah, I think ideally it is the safe and sensible thing to do.
Grand. Okay, so I think we've reached Naomi Beer. I don't know if she's here, but she had a very interesting case discussion, which I thought we could use if we had time. I think that's probably gone over, but I wonder if you'd be able to address that in maybe an email, Will, or a text later. Would that be possible?
Yeah, sure.
There were some other questions which aren't really around respiratory, but were asked, and Will has kindly agreed to answer some of them if he can. I think we're going to park. I know that 7 or 8 of you, Haroon, Nadia from Newham, Tahir and Rupert from Waltham Forest, Rajivi from Tower Hamlets, Lucy Langford from Newham, Swapna from Havering, and Nazreen from Redbridge. We're all asking about long COVID, and I think that's, as Sabina has just said, that's a topic in itself. So we'll come back to that. I know that we've been talking in CPINs about trying to arrange a long COVID webinar too. But other questions are, when a COVID positive patient is no longer infectious to others? I think we've covered that one off from Judy, Meridia in Newham, and Chandrakant Patel. There's a bit of guidance for pregnancy and pregnant women with COVID and vaccination from Carolyn and Nejim from Westminster and Hammersmith. Wow, welcome to West London. I think the guidelines have changed slightly on that, and I think you've got chapter and verse, haven't you, Will?
So yeah, I had to look it up, but I don't pretend to be a vaccinologist, but I'm sure you all know this, but the Green Book is amazing. And basically the Green Book on pregnancy for COVID vaccination says pretty much like the BNF says for everything on pregnancy, it probably won't do any harm. There is no evidence, therefore have a discussion with the patient and delay it if you can. When I send these slides out, again, that's the hyperlink to the right bit of the Green Book for the COVID chapter. But yeah, that's the summary. It's almost certainly safe, but equally if the patient can shield, that's probably even safer. The
Royal College of Obs and Gynae came out with some guidelines on the 30th of December, just before the new year. Certainly for those of us who are vaccinating, up until that point, it was a contraindication to give the Pfizer vaccine if you're breastfeeding or pregnant. The guidelines that the government have now changed, in fact, they haven't changed the guidelines, but they've included the potential to vaccinate both pregnant women and those who are breastfeeding, given a balance of risk that is agreed by the patient. There is no evidence of safety, but there is no evidence of harm. So I hope that's answered that question. There's a potential about a hospital, and I know Lily was with us. I'm not sure if she's left, but both Lily and Spiros were mentioning ideas about hospital and home, hospital without walls. I think that will probably come, but we've discussed it a little bit today, but I'm sure that's going to come again in the future too. But I think that's covered all the topics that people asked. If there are any residual questions, as we're at 7:47, if you pop them in the chat straight away, but otherwise, I'd just like to thank everyone for participating, and thank you so much for providing all the questions for Will. It's been quite a marathon going through them, but amazing, Will. Absolute hats off to you for coming along and answering all the questions tonight. Thank you so much.
Not at all. My absolute pleasure. Thanks for having me. I've really enjoyed it, and great to put some faces to names as well. So thank you all.
Grand. If you Will, if you and Roberto and Ekram and I just hang around at the end, we can debrief a little bit and take it forward. Thank you very much, everyone.
Thanks.